So welcome, my name is Mary Jo Strobel, and I'm Executive Director for the American Partnership for Eosinophilic Disorders. I'll be your moderator for today's webinar. APFED is grateful to have received funding from Sanofi and Regeneron to enable us to offer today's special pre-conference webinar in advance of our annual patient education conference that we are hosting July 11th through 13th in Bethesda, Maryland, and online. It is my great honor and pleasure to welcome Dr. Mirna Chehade to our webinar today to teach us about eosinophilic esophagitis, or EoE for short, including goals of EoE management, treatment strategies, and ways to assess if EoE is under control. Dr. Chehade is Professor of Pediatrics and Medicine at the Icahn School of Medicine in Mount Sinai, New York, New York. She is founding director of the Mount Sinai Center for Eosinophilic Disorders, which provides cutting-edge clinical care, research, and support for patients and families living with eosinophilic gastrointestinal diseases. She treats both children and adults with EoE and has made significant contributions to the field that have advanced our understanding of this chronic condition. Welcome, Dr. Chehade.
Thank you very much, Mary Jo, for the kind introduction and also for inviting me to speak today. It's truly a pleasure to be among all of you. Thank you for all of those who logged in on Zoom. So thanks again. The topic I was asked to talk about is your EoE under control? Therefore, what I'll be doing over the next 40 minutes is go over the basics of EoE, including diagnosis and management, adding pieces of advice here and there at each level, which I hope will be useful to many of you, regardless of where you are with your journey with this disease. This is where I work. This photo was taken in the afternoon with the sun setting to the west. And in the foreground, you could see the Mount Sinai complex on the Upper East Side of Manhattan. I've established the Mount Sinai Center for Eosinophilic Disorders in 2007, and we've been very busy since providing medical care and research advances for patients with EGIDs, including EoE. These are my financial disclosures. I'll be limiting my talk to only what's published or is in the public domain so that no conflicts of interest are created. Let's start with the definition of EoE. EoE is a chronic, immune-mediated disease of the esophagus, where you have to have two things to qualify for that diagnosis. Number one is esophageal symptoms, and number two, eosinophilic inflammation of the esophagus. It is thought to be allergic in etiology, and the triggers for EoE causing the allergic inflammation are almost in all patients food allergens. And in a small percentage of patients, around 10% or so, environmental allergens can also contribute to EoE. So how common is EoE? And who is more likely to be affected by EoE? For that, let's look at the EoE prevalence, which is the proportion of people affected by EoE in a given period of time. And as you can see in the graph, the y-axis here is the prevalence per 100,000, and the x-axis shows you the years. And as you could see, the prevalence of EoE has been increasing over the years in many parts of the world. The current prevalence of EoE is estimated at 0.5 per 1,000 inhabitants. So what does that mean? If we do the math, that is one person out of every 2,000 people has EoE. You may think this number is so small and then think, was I this unlucky or was my child this unlucky? The answer is not quite, as EoE tends to be concentrated in certain clinical scenarios. That brings us to demographics of EoE. EoE occurs more often in patients less than 50 years of age. EoE is 3 times more common in males than in females. It is found in up to 7% of patients undergoing endoscopy for any reason. And it's found in almost up to a quarter of patients undergoing endoscopy for dysphagia, which is trouble swallowing food. In fact, it is the most common cause of esophageal food impaction. This is when the food gets stuck in the esophagus on its way down to the stomach. And EoE is more common in patients with food allergies, and by that we mean IgE-mediated anaphylactic type of food allergies. And it's more common in patients with atopic diseases. These are the allergic diseases such as asthma, allergic eczema, and seasonal nasal allergies. To illustrate my point, I'm referring you here to a multi-center study that we conducted a few years ago. The study included 705 children and adults with EoE. And as you could see in the graph, a significant percentage of patients with EoE had one or more allergic diseases, including allergic conjunctivitis, which is an allergy affecting the eyes, causing burning, itching, redness of the eyes, allergic rhinitis, that's the seasonal allergies affecting the nose, asthma, atopic dermatitis, that's the allergic eczema, and food allergy, and by that we mean the IgE-mediated allergy, which can cause anaphylaxis, and drug anaphylaxis. So that is the anaphylaxis in response to certain medications. Diagnostic delay is really common in EoE. Therefore, you're not alone if it took a while before you or your child got diagnosed with EoE. In the same study that I referred to you earlier, we found that the time from symptom onset to diagnosis was 1 year in children less than 11 years of age. It was 2 years in patients 11 to 17 years of age, and a whopping 4 years in adults. What we also found was that presence of food allergy and atopic dermatitis, which means allergic eczema, was associated with a faster diagnosis. Therefore, once you have received the diagnosis of EoE, you want to learn as much as you can about symptoms, how to treat it, and how to monitor it. So let's start with symptoms. Symptoms vary with age. If we look first at adults and adolescents, most adults and adolescents with EoE have dysphagia, which is trouble swallowing food. Some of them can also have intermittent esophageal food impaction. Again, that means the food getting stuck in the esophagus as it's traveling from the mouth to the stomach. This is the majority of the patients. However, some patients can also have chest pain that is in the substernal area, which means right under the breastbone in the middle of the chest. And some of them could also have heartburn. Chest pain and heartburn in these patients are typically refractory to antacid treatment if they are due to EoE. And they could confuse the patient, thinking they may have just plain reflux if they're present alone. Therefore, we need to think about them in the context of EoE. Children are more tricky, since while some can have dysphagia and food impaction, most of them have non-specific gastrointestinal symptoms. These can include abdominal pain. Typically, it's in the top part, in the middle top part of the abdomen. They can have intermittent vomiting, and many of them can have failure to thrive. In fact, up to 30% of children with EoE can have failure to thrive. Fortunately, once you fix the EoE and fix everything that is problematic around it, and we'll talk more about these, you can reverse failure to thrive. Infants and toddlers are the toughest to diagnose. Some of them can have gastroesophageal reflux symptoms, but many of them have symptoms that are simply centered around eating, around food, around feeding, so feeding problems. So many of them will start coughing or gagging with food. They may have feeding difficulties, and they may have food refusal. These are the super picky eaters, and many of them can also have failure to thrive. So it's important, if you or your child have EoE, and your child have these non-specific symptoms, to think, are these part of EoE or are they separate from EoE? Therefore, it becomes important to know that so that you can really monitor the disease appropriately, and knowing how to monitor and what symptoms while receiving a treatment. In all ages, it's important to forget that all patients, adults and children, develop compensatory feeding behaviors in order to reduce the intensity of their dysphagia and to prevent having food impactions. And these can include prolonged chewing, drinking with every bite of food, cutting food into very small pieces before they put it in their mouth, lubricating tough or lumpy foods with condiments or dunking them in liquids so they become softer before they eat them. Some of them also do avoid tough or lumpy texture foods such as meat, chicken, rice, sticky rice, dense pancakes, potatoes, etc. And many of them also have trouble swallowing large pills, so they tend to avoid them. So this is important to keep in mind. So not only we are trying to look for symptoms that are obvious, but it's important that we keep in mind how are we eating if we are a patient with EoE. So if you're, and the other important point here is swallowing pills. So it's very important if your esophagus is inflamed, and especially if you have esophageal narrowing and or stricture, to always ask any doctor that gives you a prescription whether this is in the form of a large pill. If it's in the form of a large pill, ask for a chewable, ask for a gummy, ask for a liquid medication. And this is not the time to be shy about it. You can educate them and tell them that you have EoE, therefore the pill can get stuck. So what are the complications of EoE? EoE is a chronic disease. Therefore, if left untreated, or if it's partially treated or inadequately treated or suboptimally treated, it can lead to complications. So complications of uncontrolled EoE at all ages includes the formation of scar. So what you do is EoE starts with an inflammation, then the inflammation can lead to scar formation. So now you have both inflammation and scarring, which is fibrosis. And then the fibrosis can become more advanced, leading to esophageal narrowing and or an esophageal stricture, where the food can no longer pass easily through the esophagus. Now keep in mind, not everyone develops scarring, and not everyone develops scarring at the same speed. But we know that this complication is possible. And since inflammation is what contributes to scarring, you want to treat the inflammation before scarring starts to develop. Children have even more complications than adults, as they have multiple problems that can happen from their symptoms. So their symptoms of EoE can include vomiting, abdominal pain, dysphagia, and early satiety, which means feeling full very quickly after a few bites of food. That can lead to disrupted eating. They'll have fear of eating. They may have selective eating, in other words, very picky eating. They can have a reduced appetite, and they could start refusing food. When this happens, this can result in a reduced caloric intake and poor nutrition, which has its own consequences, including decreased energy levels, nutritional deficiencies, and faltering growth. Disrupted eating can also cause a negative social impact, as they cannot socialize the same way as all the other kids. Disrupted eating can also cause impaired oral motor skill development and a disruption in the acquisition of feeding skills, especially if EoE develops in the first 2 years of life, when this development is crucial. And now you can get a disrupted relationship with food. In those cases, a feeding therapist may need to be consulted and help with the care of that child with EoE. So now that we talked about symptoms, we talked about complications or potential complications of untreated EoE, let's talk about how do we properly diagnose EoE. So diagnosis. According to the newest diagnostic algorithm, if you have a clinical presentation suggestive of EoE and your doctor performs an upper endoscopy with biopsies demonstrating eosinophils in the esophageal lining, as shown by 15 or more eosinophils per high power field, then the next step your doctor would do is to evaluate for non-EoE disorders that cause or potentially contribute to eosinophilic infiltration of the esophagus. And if none are there, then you have EoE. So what does the doctor see on endoscopy? There are features which we refer to as inflammatory features. These are the features that we see early on in the disease when it's still in the inflammation stage. And these can be edema. Edema means swelling or quote unquote puffiness of the esophagus, as you could see here, or furrows. These are the ridges that go down the length of the esophagus. White exudates can be present in the inner lining of the esophagus. They used to be called white plaques in the past. And sometimes white exudates can be seen lining up along the furrows in the esophagus. These features can be seen both in children as well as in adults. Now, in adults, and even in children, if the disease is left untreated for a while, now we start developing what we call the fibrostenotic features. In other words, the features that result from scarring from untreated disease. And these include rings, as you could see here, or a stricture. You could appreciate the stricture right here, where the esophagus now is so much narrower than if we look at this outside area of the esophagus. Again, this is more commonly seen in adults, but also can be seen in teenagers, and we've seen many that have had the disease for a while, where the inflammation is ongoing, leading to these problems. So now your GI doctor takes biopsies, which are tiny pinches of tissue that go under the microscope. And then another doctor, this time the pathologist, looks under the microscope after they stain the tissue and color it and makes little sections to examine. And here on the left side, you could see a section from a biopsy of an individual with a healthy esophagus. So you could see the building blocks of the inner lining with 0 eosinophils. In contrast, on the right, you could see a section from a biopsy of a patient with EoE, and all these pink cells here are all eosinophils infiltrating the building blocks of the inner lining of the esophagus. Finding 15 or more eosinophils per high power field under the microscope qualifies the patient of having EoE using the tissue diagnosis. Keep in mind, though, that EoE is a patchy disease, which means the inflammation is not in every single area of the esophagus. It could hit in different parts. So multiple biopsies from different parts of the esophagus are needed so that the disease is not missed. So we talked about non-EoE causes of esophageal eosinophilia. What are they? The list is long, and you can see it here on your slide. Common ones include acid-induced gastroesophageal reflux disease, other EGIDs or eosinophilic gastrointestinal diseases with esophageal involvement, celiac disease, Crohn's disease, hypereosinophilic syndrome, drug allergy, etc. And your doctor will not make a list and go through them one at a time, but they will exercise their clinical judgment to know if any of these are accounting for the esophageal eosinophils, and then do the tailored workup accordingly. EoE can have a high burden on you as a patient or as a parent or caregiver. Therefore, a doctor that understands this burden and takes into consideration all of these from all levels when deciding on a treatment is crucial for success. The burden can be divided into various categories. There's the burden due to symptoms, which include dysphagia, vomiting, food refusal, failure to thrive, etc. The burden can also come from comorbidities and complications. These are the other conditions that are usually associated with EoE, including atopic diseases, which is the allergic diseases, or stricture formation. The burden can also be psychosocial. Many patients with EoE struggle with anxiety and or depression as a result of what they go through. Some of them have missed school days, and many of them have social difficulties, especially when they cannot eat like every other person. There are financial burden on patients and their caregivers, including direct costs, for example, in the form of costs of outpatient visits, endoscopies, pharmacy costs, but also we cannot forget about the indirect costs, for example, missed work days to take care of EoE. Therefore, a treatment that takes all of these into consideration is really key. So what are the treatment options and what are the overall goals of treatment? I'd like to remind you again here that EoE is chronic and can lead to complications if not treated. Therefore, you want a treatment that can induce disease remission, which means drive EoE into being controlled or healed. You also want a treatment that can maintain disease remission, so that treatment will be ongoing and keep the EoE under control. You want a treatment that can prevent and hopefully reverse complications if they have developed. You want the treatment that would have the minimal side effects for you, and you want a treatment that will improve the quality of life for you. So treatment categories can be summarized in the acronym 3Ds. That's diet, drugs, and dilation. I will not be discussing esophageal dilation in detail, as dilation consists simply of a mechanical stretching of the esophagus when it's narrow. It does not address the underlying esophageal inflammation and therefore does not prevent further complications. As a result, dilation should typically be used as an adjunct treatment along with diet and or drugs and be used only when needed. So let's start with diet. Before we go over the different types of diets, it's important that we make a distinction between food allergy causing anaphylaxis and food allergy causing EoE. And food allergy causing anaphylaxis, it's usually mediated by a molecule called IgE. So the allergist that will see you can do skin prick tests and can do blood allergy tests to identify these foods. However, the food allergy causing EoE is cell-mediated. It's not mediated by IgE. So those tests that are done for anaphylactic allergies are not helpful to identify the food triggers for EoE. Unfortunately, we do not have good tests available to identify the specific food triggers for every patient with EoE yet. So there are several different diets developed to circumvent this. Historically, 3 types of diet have been extensively described and published and have therefore become standard of care. The first one is the elemental diet. This is a diet where you would remove all food from your diet and you are fed exclusively with an amino acid-based formula, which is a non-allergenic formula, plus or minus 1 or 2 foods. And as you could see here on the y-axis is the histological remission rate, which means the rate of healing the esophagus from eosinophilic infiltration. And the efficacy rate is really high, both in children and adults, but it's a very difficult diet to follow. Therefore, it is reserved for very severe situations. Then there's the allergy test-directed diet, where foods that test positive by skin prick test and or ATP patch test are removed, and this diet has not done too well, unfortunately, and therefore is currently being discouraged. Then you have the empiric 6-food elimination diet. There is a diet where foods are removed empirically without any testing. And these consist of milk, wheat, egg, soy, all nuts, and all seafood, with a reasonably good efficacy rate of around 70%. However, removing 6 food categories is still very restrictive in life. Therefore, more diets that are more abbreviated have been tested over time. So these consist of the 4 food elimination diet, where milk, wheat, egg, and soy are removed, the 2 food elimination diet, where milk and wheat are removed from the diet, and the 1 food elimination diet, where only milk is removed from the diet. And when we say milk, for example, this doesn't mean just milk. This means milk and milk products. So that's cheese, yogurt, milk and a baked product, etc. So if we look at the response rates for these diets, the fewer foods we remove, the less chance of the EoE healing completely, but the better the quality of lives. So it becomes a matter of balance in terms of decision as to what diet is best for you given your specific circumstances. So if we look at the different diets and their efficacy in one graph, we see that so this is efficacy here in percent, and these are the diets. If we go from the bottom all the way up, elemental diet has the highest efficacy rate because it's the most restrictive of all of them, followed by the 6 food elimination diet, then the 4 food elimination diet, then the 2 food elimination diet. You can see here the allergy test directed elimination diet is just above that. And then finally, we have the 1 food elimination diet, which is the milk elimination. Therefore, in an uncomplicated situation, starting with simple milk elimination should be considered in treating EoE. What about medications or drugs? So one category of medications are proton pump inhibitors. These are strong antacids, typically used to treat acid reflux, but they were found to have an anti-inflammatory property in treating EoE. Examples of these drugs include omeprazole, lansoprazole, and many others. The efficacy rate of these drugs is around 50%, whether we're dealing with adults with EoE or children with EoE. Once PPI, they're abbreviated as PPI, once PPI work, you will need to continue that PPI and aim to see if a lower dose will work for you on the long run. Another category of medications are topical corticosteroids. Up until very recently, when we got the first FDA-approved topical corticosteroid for EoE, we have been using off-label medications that were repurposed from another disease to be used for EoE. One of them is the fluticasone HFA inhaler to swallow. This is actually an inhaler that's usually patients inhale for asthma, but we ask patients to puff and swallow the mist instead of inhaling it, so it coats the esophagus. Another one is budesonide. This is a raspiol that has a liquid budesonide that's usually used for nebulizers for patients with asthma. Instead, we tell them to take the liquid and thicken it with a sugar substitute or maple syrup, etc., to make it viscous, so when they swallow it, it will coat the esophagus and treat it on contact. Typical induction doses here are 880 micrograms twice daily for fluticasone and 1 milligram twice daily for viscous budesonide. And the efficacy rate, based on several trials, is around 65%. More recently, a multi-center phase 3 trial was conducted in adolescents and adults. What is a phase 3 trial? That's the trial which has a lot of patients involved, which is at a stage now where results can be submitted to the FDA to decide whether the medication can be FDA approved. And by the way, because of the limitation in time, I will only be discussing medications that went through the phase 3 trial or are currently in phase 3 trial. So back to this study, the treatment was done for 12 weeks and patients received an extension up to 1 year. The dose that was tested was 2 milligrams twice a day of the budesonide. And if you could see here on the left, the proportion of patients that achieved healing from esophageal eosinophils was significantly higher in the budesonide treated group compared to those that received placebo, which is the dummy medicine. And if we look to the right, the proportion of patients that had a clinical response where their symptom score of trouble swallowing was reduced was significantly higher in the budesonide-treated group compared to placebo. And that has led to the FDA to approve this medication for patients 11 years and older for 12 weeks. What about a tablet? You may wonder, is there a dissolvable tablet? In fact, yes, there is a budesonide oral dispersible tablet. This was a study that was a multi-center phase 3 trial that was conducted in adults, but only in the European Union. The treatment was given for 6 weeks, and the dose that was tested against placebo was 1 milligram twice daily. And what they found was the percentage of patients who had both symptom response and tissue eosinophil response after 6 weeks, it was significantly higher in the budesonide-treated group compared to placebo. And that has led to approval of the drug by the European Medicines Agency, which is the equivalent of the FDA for Europe. So this drug is only available in Europe, and I believe in Canada as well. What about the US? Do we have a dissolvable tablet? The answer is we have one currently under study, and that is fluticasone dissolvable tablet that's currently being tested. This is a multi-center phase 3 trial in adolescents and adults. Treatment is for 6 months, then extended to a year. The dose that is currently being tested against placebo is 3 milligrams once a day at bedtime. So we just have to wait to see the results. How about a third category of medications, and that is biologics? Before we go into biologics, let's just explain a little bit the immunology or immunopathology of EoE. The immune reactions occurring in the esophageal lining of patients with EoE is complex and not just limited to eosinophils. So if you look at the tissue by special staining under the microscope in the laboratory, you will see that in addition to eosinophils, there are many immune cells responsible for the disease, including other white blood cells besides eosinophils, called T lymphocytes, mast cells, etc. In addition, there are molecules that increase in the esophagus and are responsible for inviting those immune cells to the esophagus. There are other molecules that orchestrate the communications between all these immune cells, eventually leading to inflammation and scarring. And several biologics, as you could see here, have been used to target different parts of this dysfunctional system. So what are biologics? They are molecules that specifically target an immune cell or specifically target a molecule and can therefore disrupt one or more of these dysfunctional pathways leading to inflammation and scarring. There are several that have been tested in EoE over the past 2 decades. And again, here, I will only focus on those that went through phase 3 trials, starting with dupilumab. This was tested in a multi-center phase 3 trial in adolescents and adults. Treatment was given for 6 months, then extended to a year. The dose that was tested against placebo was 300 milligrams once a week and 300 milligrams every other week. This is an injection under the skin. And the results were as follows. The percentage of patients that achieved esophageal healing from eosinophils was significantly higher in the dupilumab-treated group compared to those that received placebo. And this was seen with both doses of dupilumab tested. This effect was still seen when patients were followed after 1 year in the trial. Now, when we look at how did the patients do with symptoms related to EoE, the change in their dysphagia score was significantly higher in the dupilumab-treated group compared to those that received placebo. However, this was only seen with the higher dose that was tested, which is the 300 milligrams once a week. Therefore, the FDA approved the weekly dosing of dupilumab for patients 12 years and older weighing at least 88 pounds. This was shortly after followed by another trial in children using dupilumab. This was a multicenter phase 3 trial in children 1 to 11 years. Treatment was given for 4 months, then extended to a year. And 2 different doses were used, very much equivalent to what was tested in the adolescents and adults, basically high exposure dupilumab and low exposure dupilumab based on their weight category. And if you look at the left, the proportion of patients achieving esophageal healing from eosinophils was significantly higher in those that received high exposure or low exposure dupilumab compared to those that received placebo. And not only patients that received dupilumab improved their symptoms, but also the change from baseline in the body weight for each percentile was numerically higher in patients that received the high exposure dupilumab compared to placebo. And this is important in many patients who are suffering from failure to thrive. And the results from this study led to the FDA approval of dupilumab for patients 1 year and older weighing at least 33 pounds. Are there other biologics? The answer is yes. 2 biologics that are currently being tested in phase 3 trials include cendakimab, multicenter phase 3 trial in adults. Treatment is for 4 months, then extended to a year. And 2 different dose regimens are being tested, 360 milligrams once a week, and another one which is once a week followed by every other week. This is also an injection under the skin. Tezepelumab is another biologic. Multicenter phase 3 trial in adults is currently being tested. Treatment is for 1 year, then extended to 1.5 years. And again, 2 different doses, a low dose and a high dose of tezepelumab are tested against placebo. We'll have to wait for results of these trials. Now, all the biologics I mentioned so far do not work directly on eosinophils. But then you may ask me, why don't we wipe out eosinophils or address or attack the molecules that directly invite them to the esophagus? The answer is this was done using multiple biologics so far, including mepolizumab, racemilizumab, benralizumab, and lirentelimab. And the results of the trials were not that promising. Eosinophils, in fact, almost disappeared from the esophagus of patients with EoE in all of these trials, but the patients did not feel good enough for the results to be significant. And this confirms for us that other immune cells play a major role in EoE besides eosinophils. So now that we went through all different treatments, the different types of diets, different type of medications are currently on the horizon. This is a lot of options here. So how do we make a treatment decision? So if you're wondering, where do I start? This is a practical clinical guidance for you. If you have EoE, the first thing you need to do is ask your doctor to learn about EoE, the particular features that you or your child has. Learn about the pros and cons of each treatment option specifically for you in your particular situation, including the expected efficacy rate of each treatment for you and the potential side effects for you in particular. So when you engage in this discussion, this is what we refer to as shared decision-making, which is simply you trying to come up with the right decision for you or for your child with guidance from the doctor who's providing you the information and having the discussion with you. And sometimes this shared decision-making may not be limited to a patient-provider relationship, but also it could mean discussion among providers taking care of you to make the right decisions for you. And you may decide to go on a diet, one of the empiric elimination diets, or even an elemental diet if your situation is severe. Or you may decide to go on medications. And as we mentioned, these include proton pump inhibitors, topical corticosteroids, and even biologics. In the event of no response to one category, you could move in the same category to different treatments, whether it's in diet or in the medication category, or you could swap different categories. It all depends on what you can have that works for you and gives you the best quality of life. Now, note esophageal dilation here. It's not one of the options up here. This is an adjunct treatment, so it's an add-on treatment if there's a stricture that's significant and needs stretching. Now, anytime you respond to a treatment, whether it's a medication or a diet, as EoE is chronic, this treatment cannot be stopped. Maintenance treatment is now the key to keep EoE under control. So how do we assess if we're responding to treatment? The way we do it is by using a three-pronged approach. We monitor for symptoms. So clinical follow-up. Basically, we wonder, how are you feeling? You also need to know, how are you eating? If you're dealing with a child with EoE, how's your child with EoE growing? Then we have findings on endoscopy. How does the esophagus look like on endoscopy? And then we have findings on biopsy. What do the biopsies reveal? Are there eosinophils? If so, how many? And are there other features of inflammation in the esophageal tissue? That's very important to know. And how severe? Once you know that, that's when you know if you're responding or not. So then the issue is, how long after you started treatment would you go ahead and assess for response? You can do that anywhere between 6 weeks and 6 months. It all depends on what treatment you're doing, how severe is your situation, which treatment specifically you're choosing, and your quality of life, and many other factors. So discussion with your GI doctor and other doctors taking care of you is really important to decide on how long should you wait before you assess fully. Now, if your EoE is under control, which means that it's healed, you're feeling well, and you're not planning to change your treatment for a while, how often do you monitor EoE? So far, there's really no guideline on this, but the consensus is check the symptoms once a year with your physician and check by doing an upper endoscopy with biopsies every 1 to 3 years. You may think this is a lot of endoscopies and it may be an overkill. So far, in the absence of non-invasive tests, this is the only way we can check. And in fact, a recent study showed that gaps in care for longer than this were associated with a higher risk of fibrostenotic complications, which means development of narrowing and stricture. Finally, it may take a village to take care of your EoE or your child's EoE, depending on what you are working with and how severe it is. So in addition to having a gastroenterologist, an allergist, a pathologist that looks under the microscope, and more likely a dietitian to deal with the feeding difficulties you're having or to guide you through a dietary treatment, you may need one or more of the other specialists. Many of them here are listed on the slide, but examples include feeding therapists, psychologists, etc. So a few key takeaway messages from my talk. Keep in mind with presentation of EoE, symptoms can be subtle, they can come and go, which means they're intermittent, or they can be non-specific, where you're not sure whether they're EoE related. Therefore, not only watch for those, but also watch how you're eating, or if you're the caregiver of a child with EoE, how's your child eating? In terms of diagnosis, it's really important to diagnose it early to prevent complications. So if you have a relative with EoE or you hear of someone who may have symptoms suggestive of EoE, encourage them to get a workup early. It's also important to assess all features of EoE, the esophagus on endoscopy, and multiple biopsies from the esophagus are important for proper diagnosis, so it's not missed. In terms of treatment, please keep in mind EoE is chronic, so treatment, the one that works for you, should not be stopped. Your goal is to go to the lowest dose that works for you and creates the least side effects, or if it's a diet, the least restrictive diet that works for you and causes the fewest side effects socially, psychologically, etc. Now, the lowest dose, whether it's treatment or the least restrictive diet that works for you, means where your EoE is fully controlled. And you have multiple options now: diet, proton pump inhibitors, topical corticosteroids, and biologics. Now, what does the future hold, and what do we need really? What we need is more FDA-approved treatments. We're very happy now that we have 2 FDA-approved treatments for EoE. And as you could see, there were so many under testing currently, and many more, which I did not mention, as they're still in phase 2, which is the phase preceding phase 3, or even in very early testing phase before going into clinical trials. So we just have to stay tuned and see what medications are new and what would work for you. And what we also need is to identify different patient phenotypes. What I mean by that is to look to see, for your EoE, which category of EoE do you fall under? Do you have the EoE that's mostly allergic? Do you have the EoE where there's one specific molecule that's really high, therefore a specific treatment would work for? Or do you have the EoE that would scar very quickly and therefore you have to act fast, etc., etc.? And knowing the different phenotypes of EoE through research will allow personalized, more effective treatment. This will help us achieve the future goal of tailoring the best treatment for each patient with EoE that will ensure better outcomes. Thank you for your attention. I will take questions now.
Thank you so much for such a wonderful presentation, Dr. Chehade. I personally learned a lot today, and I hope that our audience members did as well. If you're joining us live today, please use the Q&A box to send your questions for Dr. Chehade. And I will also note that I understand the chat feature is showing as disabled. However, we are seeing your questions. We are looking into why the chat would show as disabled for you. I suspect it had something to do with the update from Zoom this week. However, we are seeing your questions, so please use the Q&A box to send in your questions for Dr. Chehade. There have been a lot of great ones that have come in while you were presenting, so I will go ahead and dive right in. Dr. Chehade, you mentioned dysphagia score, and we have an attendee asking, what is a dysphagia score, and is that something that a doctor can provide in clinic, or is that something a patient can score on their own?
Well, thank you for the question. A dysphagia score is a series of questions where a patient is asked about how frequent are they having trouble swallowing and how severe. And then the questions are tallied up with a score from 0 to 1 or 0 to 2 or 3, and eventually coming up with a total score. This is a score that's very much used in clinical trials. However, it's not that practical for to be used on your own with your doctor, as it is only reflecting what happened that day. So if you're going to use it with your doctor, you would have to fill it out every single day and then get to analyze it, which is really not that practical. So when you're discussing your EoE with your gastroenterologist or allergist or other specialists in your care, what you want to see is to tell them what happened over the past few months that you have not seen them yet. So since your last visit. So give them an idea of how long have you or how often have you been having trouble swallowing, and what foods are these that give you the hardest time? Are they doughy foods, lumpy foods? How bad is it? And also, how many times have you had the food getting stuck? So that will give them a more global feel. But in addition, please do not stop at telling them about the swallowing, because you would have adjusted the way you eat to prevent major events from happening. So tell them about how much have you adjusted the way you eat, so they can really get a good picture of how severe are your symptoms with EoE. And that in a way would obviate the need from you going through a score on a daily basis.
Thank you. Another asks if it's possible to treat EoE with medication only, or is diet always a component of treatment?
Um, Thanks for this question as well. No, you can absolutely treat EoE with just medication if you'd like. So you do not have to do a combination treatment. In fact, we did not touch upon combination treatment. We reserve combination treatments to patients who have not done well on one treatment or another. So if you feel that diet is not the right approach for you and you'd like to go for a medication, you can absolutely go ahead and do that. And vice versa, of course.
Question semi-related to that would be the role of environmental allergies with EoE, or is it always to a food?
So I would say just under 100%, 90 some percent of patients with EoE have problems with food. The most common trigger food is milk. And about 10% of patients with EoE have environmental allergens contributing to their EoE in addition to the food. There are very few patients, so these are rare, where only environmental allergens trigger their EoE. So these are really, you can count them on one or two hands at max. Otherwise, it's almost always food, with a small component having both food and environmental allergens.
Thank you. As a GI doctor, if you have an infant or a young child who has eosinophil reduction after a period of avoiding a trigger food like milk, for example, and an allergist, as part of their care team, then suggests reintroducing dairy as the form of baked milk, what are the approaches? How would two members of the care team come together to discuss the best approach for that?
Thank you. Great question. This reminds me again to re-emphasize shared decision making. So first, you have to feel comfortable that this is the right approach. Please keep in mind that when you remove a food for a long time for EoE, what we've seen is that some patients develop a food allergy, an anaphylactic food allergy of the food that's being avoided for a long period of time. And we don't know who are the patients are more likely to develop that. So what we always advocate is a collaboration between the GI and the allergist to keep testing for the food that is being avoided, regardless of whether you want to add it or not back to the diet. You want to test it just in case you get exposed to it by accident. You want to know now, are you at risk of having an acute reaction to the food? And if so, an allergist needs to do this testing. Now, sometimes the allergist might find that the level's starting to increase just a little bit, and they want to make sure that you get exposed to tiny bits of that food, like milk in your situation, as an example, so that you do not get to develop an acute severe allergy to milk by doing these little exposures. But now you're taking the risk of flaring EoE. So what you do not know is how severe or how sensitive is your EoE to milk. For some patients, tiny bits of milk will flare their EoE. And for others, they may tolerate tiny bits without problem when it's baked into a product where you have very little milk going into that food, especially if you don't eat it every day. And in that case, your GI doctor will need to follow on your symptoms of EoE and will need to perform an endoscopy to see, by adding that milk in baked product, did you flare your EoE? Therefore, was it worth it? And if it is worth it, and you feel like, I want to continue, that's when you consider adding a medication to heal that inflammation resulting from that. If you feel like it wasn't worth it, then you remove the baked milk again. So these are the little nuances here of dealing with milk allergy versus and food introductions. So what I'm going to add here is one last thing is, if you feel that now you're in between the allergist and the GI doctor in terms of discussions, and you're relaying this information back and forth, please try not to put yourself in this situation. It's very stressful. try to see if your GI and your allergist can communicate about this. And then you make a decision after you hear their common opinion.
Thank you. Another asks, what type of doctor should a person see if they first start noticing symptoms that they think are EoE?
They need to see a gastroenterologist. So that's the specialist in GI diseases. If you're dealing with a child, a pediatric gastroenterologist. If you're dealing with an adult, of course, an adult gastroenterologist. That's the first one to see. So proper evaluation is done, and then the gastroenterologist will decide whether an endoscopy is needed to confirm it if they're agreeing that it's suspicious.
Thank you. A related question to that, when it comes to diagnostics, is it always endoscopy, or is there a less invasive way to do that?
Well, to diagnose EoE, you definitely need an endoscopy with biopsies. Even though we have wonderful advances now in non-invasive technologies that are starting to emerge, and some of them are currently in use at many centers, if you want a diagnosis of EoE, you need the full evaluation. That includes looking at the esophagus, looking for other problems, ruling out other conditions, looking for reflux, looking for other features on endoscopy, such as hiatal hernia, evaluating the stomach properly, taking biopsies if needed, if there's any symptoms suspicious for that, looking at the intestine and taking biopsies from there. So a full evaluation with an upper endoscopy and biopsies is a must for diagnosis. Where do non-invasive tests fall? In following up a disease in certain specific scenarios, where if you are, for example, on a diet and you're trying to introduce foods quickly, and you know your stomach and intestine are fine, and you know you do not have other problems in your esophagus, and you want to check after every food introduction if EoE flared, that's when a non-invasive test can be handy. So non-invasive tests are good for specific indications during follow-ups, but not for the very first proper evaluation of EoE. Remember, EoE is a chronic disease. You want it diagnosed the proper way.
Thank you. And I realize we're coming up on time, but do you have a time to answer maybe one or two
Sure.
more?
Absolutely, I'd be happy.
Okay, excellent. And there's plenty of time to ask questions during the conference on July 11th, 12th, and 13th. So I would encourage you, if you do not have your questions answered here today, there will be plenty of opportunity, and we can do some follow-up perhaps post-event to gather these questions and communicate back what might still be outstanding. A participant wants to know, how long should somebody be on an elimination diet? I guess that would be true for any therapy before you would expect to see symptom improvement. And does it vary between therapies? Do some therapies take a little longer than others?
Well, typically, I think for most therapies, including diet, within 3-4 weeks, you're going to start feeling a difference. But again, this is a very big generalization, as what we're looking for here is improvement of symptoms that are reflective of improvement or reduction of the inflammation. So let's say you have EoE, but you also have a stricture where the esophagus is really narrow from scarring, and you go on a diet and you still have trouble swallowing, but you may be having trouble swallowing because of that mechanical stricture. So you may not see an improvement, even though the diet may have worked for the inflammation. So it's all individualized. But if you want to say in a simple scenario where the esophagus just inflamed, the diameter is good and it's open, and there's no problem with movement or motility, so there's no dysmotility of the esophagus that would confuse you, then within 3 weeks or so, you should start feeling an improvement. Again, there's also other scenarios where the symptoms are very non-specific. For example, you may have a child who's refusing to eat. Why, you're not going to find a major difference now in 3 weeks if they're already scared of the food and they don't want to touch the food and they refuse and they become picky. So this will take longer. So it's very much individualized depending on the symptom we're working with and what the esophagus looked like upon evaluation. But generally speaking, a typical, easy to diagnose, easy to follow symptom in a non-complicated esophagus, within 3 to 4 weeks, you should definitely see a response.
And one more question. What happens if you leave EoE untreated? Somebody is asking the very worst that could happen if you don't treat it at all. Is it significant scarring? Can it lead to cancer?
Well, we have not seen a report of cancer so far, and that's a good thing. What we've seen is patients with Barrett's esophagus, which is a precursor to esophageal cancer that really needs to be attended to. And these patients with Barrett's had concurrent reflux, so acid reflux disease. Now, what we don't know is, did the EoE make the reflux worse and therefore hasten the Barrett's? We don't know that. And it's important that we keep an eye on that to see, are we more likely now to develop Barrett's if we have concurrent reflux? So that's where the small nuance here on the cancer happens. But so far, in an uncomplicated EoE patient that does not have concurrent reflux, we have not seen esophageal cancer yet, which is good news. What we see, though, is scarring. So as I mentioned in the talk, inflammation leads to scar. Scar can deposit, more and more of it deposits, can cause trouble with the normal motility of the esophagus. So now you have more trouble swallowing because it's not moving the foods. That squeeze and release function is no longer working properly. Or you could have esophageal narrowing, where it's too narrow for the food to pass comfortably. Or you could have a stricture. So now we're dealing with an actual scar that's narrowing it visibly. So that's a risk. What's your chance of developing scar? We don't know yet. We have not been able yet to phenotype patients into those, to knowing who scars quickly, who doesn't scar quickly. Sometimes we can tell just from the way they're progressing. So if scarring is developing quickly, this is the time to be very aggressive. If not, I'd say treat the inflammation just in case you're the one who's going to progress to scar. The other complications we talked about, if it's left untreated, especially in children, there's more and more food refusal. There's more and more dysfunctional relationship to food because there's no enjoyment with food. Now you have pickiness, you have failure to thrive, and other social complications from this, social isolation, which are all complications of untreated EoE. In addition, you have the risk of having a food impaction all of a sudden. If the food does not pass quickly with a sip of water or even by regurgitating it back up, you may end up in an emergency room full of patients that are having way more urgent cases, and you're now sitting for hours in the emergency room, retching on that food and discomfort and waiting for a GI doctor you've never met to take care of it under anesthesia by removal of the food using the endoscope. So you want to prevent these complications. Since you do not know what's your chance of developing these complications, for now, it's best that we err on the safe side and treat it until eventually we can customize how much do we need to treat and who is more likely to scar quickly and get these problems and who is not.
Thank you so much, Dr. Chehade, for your insights today. And thank you to all of you in the audience for joining and asking such great questions. I'm going to do a quick screen share again. And here we go. I would also like to take a moment to extend a special thank you to our education partners, Sanofi and Regeneron, for providing APFED with the funding to support today's special pre-conference webinar. If you are watching us live today, you are already registered for our virtual access to our annual patient education conference, EOS Connection 2024. Join us for sessions online July 11th through the 13th or on site in Bethesda, Maryland. Conference details are on the URL that you see on the screen, apfed.org/conference, which is also where you will go to log in for the virtual event starting Thursday, July 11th. All conference registrants have access to the virtual conference environment, and they can connect with other attendees through our mobile app. So look for the EOS Connection app on Apple app or Google Play stores. You can recognize it by the APFED logo. You will need your email address that you registered for this webinar and for the conference to gain access. The app opens July 10th. To join us virtually to watch conference sessions live on July 11th through the 13th, you will log into the virtual conference environment either by the app or the computer. And from here, you will, via computer, have access to virtual table talks that we are hosting on Thursday, July 11th, starting at 1:45 p.m. Eastern. So for the full schedule of conference sessions, please visit apfed.org conference. So that concludes our special pre-conference webinar today. And I want to thank you for joining us and have a great day, everybody.